So welcome to this webinar about whole body PET-CT. Good afternoon from Lucerne, Switzerland. This webinar is part of the series of Swiss hybrid imaging webinars. We are very happy that we could win the team of University Hospital in Bern from the nuclear medicine department to tell us about the experience with the first whole body PET-CT installation of Biograph Vision Quadra. This is installed, I think, since more than half a year, and it will be very interesting to see their experience with this new system. Before we start, some instructions. You have the possibility to make questions in the chat here on the right-hand side. I will collect your questions, and after the presentations at the end, we will discuss as many questions as possible. We want to start now with one question to the audience to see how much knowledge you have already regarding whole body PET-CT. And Karin, please give the question to our audience. So the question is, what statement regarding the Siemens Vision Quadra compared to Vision 600 is wrong? It has a higher sensitivity, A, B, faster image acquisition, C, less radiation burden, D, the crystals are smaller, or E, time of flight is similar. Please vote. There's still voting going on. Okay. Interesting distribution. I don't tell you the right answer at the moment, but we will come back to this at the end of the presentations. Okay. We stop the voting. Interesting results. And now we start with the presentations, and it's my pleasure to introduce Axel Rominger. He is the chief of the Department of Nuclear Medicine in University Hospital of Bern, and he's the lucky guy who could install the first Siemens Vision Quadra in his department. So please, Axel, start with your presentation. We are very looking forward for your presentation.
Okay, thank you very much. I was just told that there has obviously been the introduction, which I was unfortunately unable to listen to, but I hope that you can hear me now and that you also can see my presentation. If not, I need a sign from someone. So it's a great pleasure for me to talk about whole body PET-CT imaging, and especially about our clinical experiences, which we now gathered in the last 6 to 8 months. And this is my brief disclosure. And when it comes to PET imaging or PET technology and recent improvements, I would recommend, if you are interested in that, to read this review article from Stefan Vandenberg, who illustrates quite nicely what have been the recent improvements in PET imaging. And that is especially with regard to spatial resolution and to the geometric sensitivity, and also with regard to the introduction of time of flight. A bit more in detail, and this might also be interesting then for the poll question, which you have just answered, is that the pixels, the detector pixels became smaller during the recent generation of scanners. Now we reach pixel sizes in the vision generation of about 3.2 millimeters, which already was the size with the Biograph Vision, and this still stayed the same pixel size in the Biograph Vision Quadra. And what was also introduced when we came from analog to digital scanners was the full coverage with PMs, and this altogether enables the fast temporal resolution of these scanners. With regard to sensitivity, the LYSO detectors have been introduced, the axial septa have been removed, and what we primarily also hear today, the axial length, axial field of view have been enlarged. Third component is the time of flight information, so the information content per annihilation or per photon pair, where you can determine the annihilation probability with improved time of flight more precisely. And all these things came together in or were improved in the recent years, and is now available in these latest scanners. What kind of PET systems are existing today? There are dedicated brain and dedicated breast PET scanners. I put the PET MR on a bit on the right side. I mean, that's of course also existing. And when it comes to the regular, let's say, field of view scanners, we now distinguish a bit between the standard axial field of view scanners, where there are lengths of 15 to 30 centimeters available, and now the introduction of these large axial or ultra large axial field of view scanners with extents ranging from 64 centimeters up to 194 centimeters. These are the current generations of digital PET systems from the big vendors. All of them have a digital PET system available. What has been always a kind of a problem of these standard axial field of view scanners? That was that you administered a lot of activity, and that only a minor portion of the signal actually was detected when you only cover, let's say, 20 or 25 centimeters with your field of view. And you now see here this big step forward if you increase this to more than a meter, for instance. The other thing I also briefly introduced already is the time resolution, time of flight. This already became much better coming from the MCT analog system, with a time of flight of about 550 picoseconds, and this was now improved to ultra fast time of flight performances of about 220 picoseconds, both in the Vision and in the Vision Quadra system. This is the effect of the introduction of the time of flight and the further improvement of the time of flight from the MCT, for instance, to the Vision generation. What is also interesting, in my opinion, to get an impression or a feeling of how much impact has the extended field of view and also the introduction of the ultra fast time of flight. And this is illustrated quite nicely on this slide, where we can state that, for instance, the extension of the axial field of view from 22 centimeters to over 1 meter goes in with about factor 15. For the effective sensitivity, and the ultra fast time of flight goes in with an impact factor of 2.5, and you can imagine the combination of these two even further improve the effective sensitivity of these ultra large field of view scanners. This image you might have already seen earlier, but I still want to illustrate what is 1 meter and 6 meaning if you put this on a patient with different patient heights, and you can appreciate that even up to very tall patients, you still cover the major organs and the sites of interest in most of the clinically relevant oncologic neurologic and cardiologic circumstances. And I think this is quite nicely illustrated on this slide. When it comes to total body PET imaging, this is the current landscape of available or more or less available PET scanners. So you might have heard about the Explorer system with an axial field of view of 1.94 m with a time of flight resolution of about 400 picoseconds and the resulting sensitivity. Today we primarily talk about the Vision Quadra, a bit in comparison. You can see here, of course, it has the 1.6 m, but it has a much faster, better time of flight, a bit more bore size, and also very comparable sensitivities. This I will explain a bit in more detail on one of the following slides. PenPet Explorer, this is nothing what you can get on the market currently. This has an axial field of view of 64 centimeters with a 3-ring system. It is an upgradable system. I think currently they are at the status of 5 rings, and ultimately this might be able to accommodate 6 rings in the end, but it's not commercially, at least right now, available. The installation procedure, this is the effect after 16 days of hard work. You will see more details in the following presentation of Robin Scheppers. This was back in October last year, our first patient scan on this new device. But initially also we started primarily with the characterization, physical characterization with the NEMA 2018 standard of the system. This was now just recently be accepted. This is in press in the Journal of Nuclear Medicine. So if you're interested, you can go. I think it might already be online in the meantime. And to see all the details. Some of the details I will show you here. The spatial resolution, for instance, of the Biograph Vision Quadra, here also in comparison to the Biograph Vision 600. So you see very comparable performance with regard to spatial resolution despite the longer axial field of view. So very nice. And further performance characteristics, for instance, the sensitivity. I already showed on the previous slide that we have two kind of numbers here for sensitivities. One coming from the high sensitivity mode. This is actually the mode where you will see the clinical cases from us here in the presentation. This is the mode where still a limited acceptance angle is allowed of the line of responses. So this will be opened up completely in very soon, beginning of next year. We will have the full acceptance angle, and this results then in, or this is called the ultra high sensitivity mode with the 176 kilocount per second per kilobecquerel. So when it comes to whole body PET-CT imaging, there is a broad variety of perspectives popping up or being able to perform. And this is not the final list of what can be performed with such a device. I only mention maybe the most important things. Maybe I'm missing some of them. But on the left-hand side, I try to focus on things primarily coming from the high sensitivity, which allows then, for instance, fast acquisition and ultimately results in low radiation burden for the patient. So altogether, quite clinically important features and characteristics. I will also show a bit about whole body parametric imaging today. And on the right-hand side, this might not be the primary topic of today's talk. The scientifically more interesting things, for instance, late low-dose imaging, if you want to look at immune cells or organ interactions, or organs which are not adjacent to each other, which becomes now possible, the brain-gut axis or brain-spine, brain-heart axis, multi-tracer studies, and also drug discovery, we think will be improved in future with this device. Some image impressions. How do these PET scans look like? I present here two different reconstructions, a 10-minute acquisition here, and in comparison, for instance, only a 4-minute acquisition. This is the maximum intensity projections and some slices through the thorax, and you see, for instance, a feature which you see in these new digital PET-CT systems, that, for instance, the aortic wall shows up quite, or takes up the FDG. In recent scanner generations, you would have made out of this in vasculitis, for instance. So with these devices, you should not misinterpret this as a vasculitis. I will show you later also an example of a vasculitis. This even looks then more uptake. Another interesting case where you can delineate very nicely here the extent of the hypermetabolic lesion in the right breast here in this mama carcinoma patient. She was in prone position on the scanner, and a very nice delineation of the hypermetabolic tumor extent, for instance. I told you I show you in comparison also really a vasculitis, or a patient with a history of headache. And the question for vasculitis, we did a later acquisition, 120 minutes post-injection, 3 megabecquerels FDG per kilogram, and you can very clearly see here the high uptake in the aorta, but also subclavian and carotid arteries here. So like this, really a vasculitis looks like, and I think it also shows quite nicely how well represented all the organs are, and how clear actually the PET scan is. Another case, also non-oncologic case, negative MRI with a septic patient, where the question was, where is the focus? You see quite some instrumentation here in the lumbar spine, and also in the pelvis in this patient. And you can see here quite nicely that on the right hand side of the instrumentation there is this circular uptake here. So obviously there is some kind of implant infection of the right screws actually, and also down into the sacrum. But in these patients, it's always important not to be happy about the first finding, but continue looking also, in this case also to the feet, where we also then found that in addition to the lumbar problem, there is also an abscess via the tendon sheath in the left foot, and also in the plantar foot muscles, which can be seen quite nicely here on this sagittal view. Another interesting case, and this teaches two things, or shows two things, I think. First, in comparison, how is the performance or the image quality with an MCT system, for instance. At that time in 2020, we did applied 3.5 megabecquerels, and we imaged for 16 minutes. It was a patient with a malignant melanoma, and you can see here and find here the axillary lymph node metastases here, which was then resected and irradiated, and that was then already, this follow-up happened on the Quadra. We reduced down to 3 megabecs, and also the acquisition time was reduced down to 6 minutes. You see here quite nicely the difference between the two scanners. Very nice representation, in my opinion, here with the Biograph Vision Quadra. And then we did a follow-up scan just recently, where we then again found these hypermetabolic lymph nodes here in the subclavian and also supraclavian area. and that was early this year when this was not yet so obvious with the fact that after the vaccinations you might get this finding. But once this was then clear, I mean, we went into the history of the patient and found out that, for instance, 2 days earlier, the patient was vaccinated against COVID. You can also then see the uptake in the deltoid muscle, and these were then reactive lymph nodes, so no recurrent disease. So of course, these scanners do not prevent from these kind of pitfalls. So this is another kind of teaching point today, maybe, or in 2021. But it shows quite nicely here the difference in the image appearance of the two scanners. The brain, one example how the brain looks like, both on the Vision 600 and on the Vision Quadra. I think also a very nice representation of the gyri and sulci, and quite a lot of details you can really see on the PET imaging. And I think this kind of triangle illustrates our problem, or our opportunities we have if we would like to achieve a top diagnostic quality. We have two parameters which we can adjust. So one thing is the megabecquerel, so the injected activity. This of course correlates then with radiation exposure of the patient, and on the other hand side, the timing or the time of acquisition, how long do you acquire, and this has an effect of course on the throughput and also on patient comfort, and this of course interferes with each other, but controversially. So this I would like to illustrate a little bit with this case, where we have, in comparison with this Vision 600 patient in a lymphoma patient, where we acquired for 12 minutes on the Vision 600, and then did acquire afterwards on the Quadra, and did the reconstruction for 6, 4, and 2 minutes. I think the diagnostic quality or image quality remains very stable, even in these 2-minute acquisitions. And then we ask ourselves, what would have been, or how much activity would we had to inject if we would have scanned for 12 minutes, for instance. And this is a very easy calculation. You are actually ending up with about 30 to 90 megabecquerels if you would have scanned the patient for 12 minutes and not only for 2 minutes, actually. You can drive this even further and push to the limits and do only a 15-second acquisition. You can do the same calculation, and you're ending up with something between 5 and 20 megabecquerels, where actually then the PET component becomes more or less negligible with regard to radiation burden. No sooner said than done. We went on and did some low-dose imaging. This is an example where they only apply, for instance, 0.8 megabecquerels per kilogram in an adenocarcinoma patient of the lung. Also here, to be safe, we acquired for 20 minutes, but these are the shorter reconstructions, and you see down to 4 minutes. Actually, you have a very preserved image quality, also here on the axial slice here. And keep in mind that it's less than 1 megabecquerel per kilogram, which was injected. So if you do the dose calculation, radiation burden to the patient, this is then less than 1 millisievert, for instance, compared to a standard patient where this results usually in 4 to 5 millisievert for the PET component. Very interesting, of course, also for children. This is one example, morbus Hodgkin patient, 8 years old, 27 kilograms, with, as you see, nodal, splenic, and also some bone manifestations. We injected 27 megabecquerels. If you would follow the AINM dosage card recommendation, you would end up somewhere at around 120, 140 megabecquerels. Of course, this dosage card was established while the digital PET systems have not yet been introduced. But here with 27, we are much below this. And you see also here, we did not scan for quite an extended time. So this is the 10-minute acquisition, here the 4-minute acquisition, also still very nice quality. This was actually the baseline then. Then the patient underwent chemotherapy 2 cycles. And then we said, if we reach with 27 megabecquerels and the 6 or the 4 minutes still this quality, we go further and only inject half of the 27. So we ended up with 14 megabecquerels. And this is the reconstructions here with the 12 minutes and down even to the 4 minutes. You will see, luckily for the patient, the disease has gone, no hypermetabolic lesions at least anymore, and you should then compare approximately this and that. So the 6-minute acquisition and the 12-minute acquisition here, or the 4 and something between, and here the 8-minute acquisitions. So I think this is really a tremendous performance in these children with 14 megabecquerels. So here I would like to illustrate a bit the options with children. So there are 2 options, I think, where you inject, for instance, a regular dose. This results or allows ultra-fast acquisition, and this might avoid anesthesia in certain kids, and potentially also copes with non-compliant kids who are maybe able to lay in the scanner for 1 or 2 minutes, but not for longer. So there you would have the option to inject a more or less regular dose and do an ultra-fast acquisition. In the other case, you can, of course, inject a low or ultra-low dose, as we did in this kit here. Then you, of course, need to do a longer scan, but then the focus and emphasis is on to avoid as much radiation burden as possible. This is the first paper which was now published from our group recently, showing the clinical performance also in a head-to-head comparison with the Biograph Vision 600, where we have this kind of finding. The standard axial field of view scanner in our case was, as I said, the Vision 600, and in comparison, shorter reconstructions on the Biograph Vision Quadra with a very nice and quality. And we did look at primarily the signal-to-noise ratio, where we found comparable results compared to the standard axial field of view scanners with the 2-minute acquisitions in the Biograph Vision Quadra, and this compared to the 16 minutes in the standard or the Biograph Vision 600. Ultra-short acquisitions, or the deep inspiration breath hold. I would also like to show you one example here in an adenocarcinoma patient in the upper lobe, but then we also found here in the lower lobe, adjacent to the diaphragm, 2 nodules here. And in the regular breathing PET acquisition, 4-minute acquisition, we did not really get a PET signal. So currently there is no motion correction yet available in the system. And then we did the deep inspiration breath hold for 10 seconds, and we have a very nice hypermetabolic activity of these 2 nodules. Late imaging, also a publication which was just recently accepted in the European journal, where we did kind of later acquisitions of gallium compound, gallium PSMA 11, so the regular 1 hour post-injection acquisition is shown here on the left-hand side, and on the right-hand side, 4 hour post-injection. For our post-injection acquisition, we'll see that the background is almost gone, and this actually results then in the highest contrast, which is possible probably to achieve, and while still pushing the diagnostic sensitivity probably to the maximum. Also here, with regard to tumor to background and signal to noise ratio, this both improved in the 4-hour post-injection acquisitions compared to the 1-hour post-injection acquisitions. Further examples with F18 PSMA ligand here in comparison again to the Vision 600, 12 minutes. You get this CAL metastases here for free, because it's still in the field of view. In this case, of course, it does not change anything for the patient, but you can appreciate here that also down to 1 or 2 minute reconstructions or acquisitions, the diagnostic image quality is still maintained quite nicely. Gallium examples here, short half-life, of course, as you know, generator product availability is sometimes a problem. So also nice options in this regard here. An example is pancreatic lesion. Also here then on the axial slice, you very nicely see also in the only very short acquisitions, you can depict the pancreatic lesion. Another example in a neuroendocrine tumor patient with a liver manifestation, but also then adjacent here in the peritoneum, these hypermetabolic or these SSTR positive lesions here, also very nice diagnostic quality for this peritoneal involvement. Primary hyperparathyroidism with the F18 choline here. These are the 1 minute frames, for instance, here a kind of dynamic acquisition, first minute, the 10th minute. And if you add it up actually for the 10-minute acquisitions, this is represented here. I had to put a bar over this here because it might be noticeable some facial features. So you very nicely see the performance of, or the how the PET images look like, even down to very short acquisitions. Example for low count statistics here, the Yttrium 90, for instance, after radiosynoviotesis, where we did do the Y90 PET just after the radiosynoviotesis. And we did it again 1 day later, where we had a nice finding of these lymph nodes popping up here, which you would have probably missed with other scanners the other day. Zero radioembolization, also an example here after TheraSpheres administration, 30 minute scan to be on the safe side, but also shorter acquisitions are possible while still maintaining the quality, in my opinion. I think probably this is definitely interesting for dosimetric purposes, so this is something currently under investigation here. So some remaining words about multiparametric imaging, which become easier now with these devices. Of course, you not only get an SUV static image, but also the KI, Butler KI image, or the distribution volume image. And this was, of course, already possible with earlier generation standard axial field of view scanners, but it was a bit let's say, more complicated, because it had to be shuffled back and forth. Theoretically, this should be seen here now on this slide, but it does not work right now. So the patient needs to shuffle back and forth. Now, this does not work in this case. And the problem with this topic, I think, is that so far, a lot of many different heterogeneous or also complicated protocols have been used in earlier studies, and therefore the breakthrough of this dynamic imaging has not really happened yet. So I think this will definitely become easier now with this device, and I hope that you can see here this kind of dynamic acquisition just following the bolus injection of the trace, the kind of PET angiography, which you can very nicely see here. There is a new challenge which is being introduced here, that the data volume is quite high with 700 to 800 gigabytes. So this really introduces new challenges, but you can then really do the dynamic or derive the dynamic parameters for the different organs, look at different input functions here, the ascending, descending carotid artery in comparison. So quite nice. So one example I would like to show you, a clinical example in the malignant melanoma case, suffering from progression under lenvatinib and pembrolizumab, where we have the SUV image, what you usually look at, and then you have the flux or the KI image, and also the distribution volume image, where you definitely see here differences. And I think this is also some future topics or tasks to really look further into this, whether these KI or DV image can contribute to the clinical routine as well, together with the regular SUV image. So I think this is interesting for the future. I think more studies in this regard are required with regard to prognosis, patient monitoring, etc. And this will be easier with the advent of these ultra large axial field of view scanners. So let me conclude a little bit. So as I showed you, the major developments in PET imaging have been that we went from analog to digital PET scanners, and the improvements have been in with regard to sensitivity, time of flight, and spatial resolution. The trend is towards longer axial field of views. And there's always still, of course, a trade-off between lowering the dose on the one hand side and lowering the acquisition time. There are new challenges, especially with regard to dynamic imaging, which might be overcome with AI. Some things where then Robin also will primarily talk about is the local infrastructures. The scanner time is no bottleneck anymore, and it's important to take also care and involve the radiographers in all the discussions. And this is the final illustration of the performance comparing the MCT with the Vision 600 with the Quadra, where we only look at 1 minute acquisitions or 2 minute acquisitions. And you see here on this image the kind of, I call it sometimes quantum leap here when we reach the Quadra performance with a 1 minute or with a 2 minute acquisition. So the conclusion after now, in the meantime, more than 2,000 PET scan is that the concept, in our opinion, works. There is a significant reduction in acquisition time possible, and also a significant reduction in the radioactive dose, while still maintaining top diagnostic quality. And the challenge, of course, is to stratify the patients to 2 or in other centers more PET-CT scanners with potentially different performances, and you need to adapt your internal workflows when it comes to high throughput scanning. With this, I would like to thank you very much, and I would like to hand over back to Klaus. I hope this time I can hear you, otherwise I need some kind of other commands. Thank you very much.
So thank you, Axel, for this great overview about this new device. It was very impressive, very interesting cases also. I want to encourage also the attendees to type in questions. If you have some questions, we will answer the questions after the next talk. And now I want to introduce Robin Scheppers. He is actually the radiographer in the Interspital, and he has the experience with the system now from the view of a radiographer who's working really with the patients clinically on this machine. And please, Robin, tell us your experience with this system.
Yes, thank you very much for the kind introduction. I want to talk a little bit about the radiographer's point of view on the new Quadra system. So at first, I want to talk a little bit about the installation process and the local infrastructure that we have at our department. Then about the type of procedures that we run on it. And we did a little SWOT analysis after 6 months on how the machine really functions within our team of radiographers. So at first, the installation period, we started out with an empty room where before we had the Siemens MCT installed, and we got the whole scanner delivered directly from the state, nicely packed, as you can see. And then the engineers that came from the States as well and from Germany went to work. They made long hours, put some hard work in it, and they installed the whole machine. And as you can see, in no time it was there and up and running. So in 12 days, we went from the empty room to having a complete Quadra installed, and we could start scanning. But where is it installed? It's installed over here, as you can see in the PET-CT1. Then on right beside of it, we have our control room from which we control both of our systems. Like Professor Rominger told, we also have the Vision 600 that's installed over here. So from one control room, we can control both of them. Then on the other side, we have our patient uptake chambers. We have 6 of those. They are located here. And in one of these, we have a CAL 100 installed. That's the radiopharmaceutical dose administration system that we use a lot for our administrations. That saves us a lot of dose. Then we have, when we move a little bit further down the alley, we have 3 rooms where we have our SPECT CTs installed with their control rooms. And then we have a so-called hot waiting area where we install our patients after they've been scanned before the doctor will come to see them, or we put patients there that need to wait before we scan them in case they don't need to stay still in case of PSMA patients or DOTATOC patients. Then a little bit further we have our hot toilets, so where the patients will go and void just in front of the examination, so we will start the examination with an empty bladder. There's some impressions. Over here you can see our CAL 100 that's installed. This is an overview of the patient uptake chambers. So we have 3 on this side, 2 on those, and here is the CAL 100 installed. On the right top corner you see one of my colleagues positioning a patient, and this is the point of view that we have from our control room into the Quadra room. So what kind of procedures do we run on the Quadra? I will call this the standard. It's the static FDG image. That's what we do the most of it. We inject the patients with 3 MBQs per kilogram. Like you've seen before, that also has to do that we need to have some flexibility to put the patients either on the Quadra or on the Vision 600, so we cannot go that low in the dose yet. We will place the patients in a supine positions where they be head first. The arms will be above the head, and we will scan them vertex to mid-femur. So we have all the major organs within our field of view. We will first do a low dose CT, and then we take a 6-minute PET acquisition. After this PET acquisition, we can make CT scans with contrast agents if required. Then you've seen in the previous presentations the dynamic scan, where we saw the FDG running through the body. In this case, we also place the patient's spine and head first on the table. The arms will be beside the body. It's not that comfortable for the patients to keep their arms up all the time. So we keep them beside the body and we scan them vertex to mid-femur. In this case, we will first perform the PET acquisition and we'll do the low dose CT afterwards. So we have a filled bladder on the CT as well as on the last PET images, so they co-registrate nicely. We will acquire them for 65 minutes, and the application will be done by hand in this case. So we applicate the FDG by hand, and we need to use 2 Heidelberg extension lines of 75 centimeters to inject that one correctly. We will flush the application down with a 50 milliliters saline bolus. Some non-standard procedures that we can perform as well. If necessary, we can scan patients in a prone position. As you have seen in the previous presentation, we primarily perform those for MAMA patients. We can perform them sideways, so the patient will be on his side. This is mostly done in immobilized patients or patients in pain, so they can't lay on their back even for these 6 minutes. So we'll place them on their side, stabilize them, and scan them in such a way. Another option that we have is the table extension. That gives us about an extra 60 centimeters of table for the patient to be scanned on. In this case, the patients need to be positioned feet first. This has to do with safety of the extender. And also, most of our patients that we scan with an extender are sedated. They're coming either from an ICU or another type of intensive care. So they're connected to a lot of breathing tubes, heart monitors, stuff like that. And normally those tubes are not long enough to go all the way through and back to the front. So we will scan them feet first. So that's even possible. This table extension we also started to use. Now we have started testing with CBN imaging, and that has to do with the layout of the table. We need a little bit more space on the table then. We working on our PET-CTs with 6 radiographers. You can see my colleagues on the right image. That's our team, which we scan all our patients with. And like I've told you before, we did a SWOT analysis after 6 months of clinical experience, just to have a look at it. What are the strengths to weaknesses compared with the Vision 600 that we have installed as well and have quite a lot of experience with. The strengths that we found are the 106 centimeter axial field of view with the high spatial and time of flight resolutions, like you've seen before. And this gives us a lot of opportunities in scanning shorter. So we have shorter acquisition times that leads to less motion artifacts we have experienced because patients are not as long on the table as they used to be. So there isn't that much time for them to move around, and it's easier to stay still for 5 minutes than for 12 minutes. The patient comfort went up through this. Sometimes patients are really surprised that the scan is already done. They expected it to be way longer, and if we take them out after 6 minutes, they're usually quite happy with it. And also the throughput of patients went up because we have shorter acquisition time. We can scan more patients in the same time period. And that's all due to these 2 big points, of course. The weaknesses that we found is the bore. As you can see on the images, the bore of the Quadra is significantly longer than of the Vision, which means that the patients are mostly completely enclosed within the bore while scanning. What makes it particularly hard for claustrophobic patients, and also the accessibility to the patients is not as good as we used to before, which means we need to have longer extension tubes in case of a contrast agent that's being connected, or a dynamic scan that we wanted to start and we have an IV placed in the arm. We need longer tubes for almost everything. And also the QCs take longer because we have 4 detector rings instead of 1, and they all need the same QC. One of the solutions that we found for our claustrophobic patients is the usage of light. At the end of the bore, as you can see on the right images, we installed a small LED strip outside the field of view of the detectors, so it's not interfering with the images, and it enlightens the bore. in which it appears shorter for our patients, and we found that patients are more comfortable to lay down in an enlightened bore than in a slightly darker bore, as you can see on the left-hand side. For the QCs, we use a solid Germanium 68 phantom, and we do a daily QC. The daily QC on this machine can take up to 3 hours. It depends a little bit on the strength of the phantom, of course. But because we don't want to waste any time during our day, we started performing the QCs overnight. The daily QCs, we perform them always overnight. The time alignments needs to be done every 7 days and can take up about 3 hours as well. So we planned it in such a way that the time alignments are done during the weekends where we're not scanning as well, so we're not wasting any of our valuable times. A full setup is needed every 90 days and can take up to 4.5 hours. That's a really long time as well, so we're also planning those in the weekend, because it's horrible to have your scanner out for 4.5 hours during a working day just because you need to perform a QC. Opportunities that came out of our SWOT analysis are the lower injection doses. Because we can scan with lower injection doses, we don't need to inject as much MBQs to patients as we did before. So the dose for the patients is lower naturally, and also for their environment. So after they leave our department, they radio not as much as they did before. And also for us as radiographers, we get a lower dose because we inject lower. It's a one-to-one. And we also get lower dose due to less repositioning. Because of the 106 centimeters axial field of view, we can do a lot more of scanning in just one bed position. So for example, what we did before, we did a separate head and a separate body examination. Now we do everything in once. We just place the patients in a headrest and we will scan them from vertex to mid-femur completely through, and with the kind of resolutions and quality that we get from the images, that's no problem at all. So we don't spend that much time with the patient repositioning, which saves dose. We found some threats, or how I like to call them, challenges, especially in the planning. Because like I've told before, we have two separate machines, both have separate parameters, and we cannot perform any examination on either of the machines. So sometimes an examination is bonded to one machine, and in this case, it needs some secure planning from our side to not get double booked on a machine. The scan times are relatively shorter for the Quadra, so in planning you need to consider this as well. And if we all sum it up together, the biggest threats that we face in our PET part of the department are not anymore considered on the scanner itself, because we have a high resolution, a very short acquisition time, where we're much more bound by our surrounding logistics. So that's personal. So do we have enough manpower to inject all the patients, to scan all the patients, to do the planning, to do everything around it? Do we have enough radiographers for that? And also the patient uptake rooms. Have you seen before, we only have 5 of those. So we're very limited on these. And if I have an FDG patient that needs to be still for 1 hour, I cannot put two together, and I cannot inject one and have the same one next to it in such a small room. So it needs some fine planning and within your team and some great coordination to get these done and scan a big amount of patients on a day. So in conclusion, we have a high throughput of patients due to a short scanning time. which still results in a high quality of images with a lower dose, because we went down in dose injection as well. But still there are some problems, but I think these problems are manageable by solution thinking, like we did with the LADs and with putting the QCs overnight. So if you have a great team of radiographers, of physicians, of all the people around in the department, I think with some great thinking you can overcome the problems that you face as well. So I will say it's a great scanner, which much to discover in the future, and I'm very curious about what it will bring us. Thank you very much for your attention. I'm looking forward to any questions.
Thank you so much, Robin. Very interesting your experience with this device. Before we go to there are several questions from the audience. Before we start with these questions, we want to repeat the question to the audience from the beginning and see how you could improve with these presentations. So please answer again. The Siemens Quadra has a higher sensitivity, faster image acquisition, less radiation burden. The crystals are smaller, or time of flight is similar. In the beginning, the answer D was at 56%, and we'll see now. Okay. Axel, do you want to comment what is the correct answer of this question?
Yeah, the correct answer is answer D. So I had some technical problems in the beginning, so I do not know what the first result actually was. Maybe is it now even worse than before the presentation? So
I think it was 56% answer D before the presentation, but yeah, I think you clearly stated that the crystals are the same and not smaller, and all the rest is correct, all the other answers. So let's go to the questions from the audience. The first one is, what is the usual injected dose and acquisition time at the present? I think you showed this clearly. You inject at the moment 3 megabecquerels, and the imaging time is 6 minutes, but this is because you put the patients also in the vision, and then you need these parameters. So we can ask, what would be the parameters if you would place the patients only on the Quadra? Maybe you can answer this.
That's hard to say exactly. I think if you want to push to lower the administered dose, I mean, you can go down to 1 megabec or even less than 1 megabec, as you have seen. Of course, taking then into consideration as well that you need to acquire for a quite regular time what is also the acquisition time with the standard axial field of view scanner. So there is, I think, no clear answer to this question, and I think you saw the possibilities you have, and I think this is also the nice thing about this device, that you have a broad opportunity now. You can push either on the administered dose, or if you are in a hurry or whatever, and if the patient is not that young anymore, oncologic patient, of course, you might focus more on the acquisition, pushing down the acquisition time. So it's hard to really define the sweet spot, so to say, or the best trade-off. It depends really on the patient, on the circumstances in the environment, in the department here. Sometimes there is a problem with the FDG or the tracer delivery, then you have a timing issue, maybe sometimes. So I think the answer is that the great thing is that you have a maximum flexibility now with this device. Yeah.
Okay, thank you. Another question is, if you do a specific study of an organ, brain, heart or so, you can only do the TC of the reference area, and how is the acquired global study reconstructed?
No, so currently it's not possible to only scan a limited field of view. So you always need to scan over the 106 centimeters and also perform the CT over the whole 106 centimeters. So it's not possible to only switch on one of these four Vision 600, so to say. So that's not yet possible.
Another question, maybe to Robin. Do you use Quality Guard for the QC?
No, unfortunately, Quality Guard is not available for the Quadra. I don't know if it's coming or not. You probably contact the Siemens people about that, but at the point that we have it now, we still need to use a Phantom to perform QCs.
Another similar question. Did it happen that the QC was not successful over the weekend? How many patients did you have to shift until you performed the 3-hour QC?
If I remember correctly, that happened once at the beginning, that we had a failed QC over the weekend. Luckily enough, one of our teams always starts quite early in the morning, so we directly could start it a new QC. So with some shifting and some hard work, I think we could have scanned all the patients on the same day, maybe with a little delay in there, but we were able to keep it all in one day, and we didn't need to shift them to other days. So yeah, of course you lose another 3 hours in the morning, but like I said, one of us starts early, so we have some time in that, luckily.
How is the highest patient throughput achieved in practice in Bern? So how many patients per hour are possible is one question. Or
I don't know, maybe I answer. So theoretically, or realistically, I would say 5 patients per hour in our department are currently possible, which means about 3 on the Quadra and 2 on the Vision. Of course, if you want to achieve a record or so, you could even try 5 or 6 on the Quadra only. I mean, we currently defined the 6 minutes acquisition time as our standard acquisition time, because it also turned out that if you only acquire for 2 minutes, for instance, it is too stressful both for the patient and also for the radiographers. You put the patient on the scanner and then you go to the room or to the control room. You acquire for 2 minutes and then you have to jump up again and take the patient off. So that's not in the long term, that's not really feasible actually. So we defined the 6 minutes as a good compromise at this point. And but if you would like, then of course, and if you would push for that, I mean, you can do 10 patients, as I said. But of course, changing time, this is the most relevant thing. Changing time does not change, of course. I mean, this remains the same like with every scanner. But the 2-minute acquisition, as we saw, is already enough, actually, theoretically, at least.
Do you think you can reduce the uptake time also from 1 hour lower or so? Or?
I think with FDG, I don't know if that really makes then sense. So we we stick to the 60 minutes. So, I mean, anyway, then the contrast, even if you would scan later, of course, then also becomes better. So I think with FDG, that's maybe not the right direction.
One question regarding the data size. I guess there's a lot of data coming out of this machine and reconstruction and so on. Can you comment on this? How long does it take that you have the images available and so on?
Yes.
Maybe Robin, yeah.
Yes. So for the reconstruction of the data, it takes, for your feeling, a little bit longer compared to the Vision 600, because the Vision 600 already starts reconstructing the data during the acquisition. When you make a CBM acquisition, for the Quadra, it only starts reconstructing after you do the acquisition.
Mm-hmm.
So I will say about 8 minutes for a standard FDG PET. It will take between the end of the acquisition and that the first images appears on the screen. That's for the reconstruction. For the data, it's a little bit of a question like, what do you want with the data itself? Do you only want to store your reconstructed data, or do you also want to store your raw data? The reconstructed data is sent to dry quite quickly to any other systems, like a single via, a PAC system, anything like that. If you want to store the raw data as well, you need to have the right infrastructure at your hospital to save the data and have the capacity to save it as well. Like you saw with the Dynamics PET, the raw data you receive from that is 750 gigabytes of just one patient. So you need to have the infrastructure to get that out of the way and to get it stored.
Thank you. One question regarding claustrophobic patients. I think you mentioned this already, but you can state that this is a more significant problem than on a standard PET scanner.
Yes.
Yes.
But that's the short answer.
Yeah,
of course.
You mentioned already.
Yeah, and we did some things that make it more comfortable for the patients, like the lighting, and also if the patients know that's only a short amount of time that to be in there, only 6 minutes compared to 12 minutes on the other machine. That is a relief for the patients, and there is even a possibility that's in a worst case that the patient after 4 minutes is not able to hold it any longer. We can stop the scan and just reconstruct what we did in those first 4 minutes. One of our doctors will have a look at it and see if it's enough for a report or not. So that's a possibility we have that's unique to this kind of scanner because we have the big field of view.
Maybe the last question, do you think there is an advantage to use second sampling for dynamic data? This is more regarding research problem.
Yeah, so currently that's not yet possible. So we do not have a sub-second sampling, or at least we cannot extract it. So currently we are limited with 1 second frame. So this is the shortest framing we are able to achieve. But of course, it will be interesting to investigate this, whether there is then advantages with the sub-second frames or not. But at the moment, it's not yet possible.
Okay. So I think we come to the end of this webinar. Thank you again, Robin and Axel. It was very exciting, and I think we will see much more data and experience from your system in the following months and years. The attendees will receive an email with the confirmation of the attendance of this webinar. And also we want to, we send a survey and hope that you answer this survey to have a little bit of feedback of this webinar. And With this, I want to thank again also Siemens for organization of this webinar, and see you soon. Thank you. Goodbye.